Thank you. Thank you so much for the introduction, and thank you for the opportunity to speak here today. So in contrast to Dr. Idvani's task today, I feel like mine's a little bit more focused instead of the rapid-fire dash between a bunch of different histologies. But a lot has changed in the CLL world since ASH last December, and so I think this is just a good opportunity to be able to discuss the recent data and look at a systematic approach for 2019. See down here. Okay, here's our research disclosures. So just to outline it, what is the updated treatment landscape in 2019? What drugs are available? I'll review when are the indications to treat for these patients, as well as highlight some studies that are looking at perhaps earlier treatment. Which treatment should we use based on different criteria at diagnosis? I'll then talk about outcomes in the relapse setting, and then with just a few slides, try to highlight where is the future going and what's on the horizon for this disease. So just as background, CLL-SLL is an indolent B-cell non-Hodgkin lymphoma, which is incurable in virtually all patients, but is managed like a chronic disease. And there's about 20,000 new cases in the US each year. And I highlight here that observation is reasonable in asymptomatic patients, as in fact, one of the most common initial treatments for patients is observation. However, since 2014, treatment paradigms have changed dramatically when the first oral targeted agent was FDA approved in this setting. And so just to briefly talk about what the treatment indications are, this is a gray zone, and so this has to be individualized for the patients, but rough guidelines would be cytopenias, and so while there's no strict thresholds, one shouldn't treat for cytopenias alone unless the hemoglobin's below 10 or platelets below 100. It doesn't mean that one must treat when they're below this level, but it's a discussion that should start around that level and be taken into account for other symptoms. Symptomatic lymphadenopathy, hepatosplenomegaly, constitutional symptoms. If someone comes in just complaining of fatigue and nothing else, I don't use that as an indication. That's one of the hardest things to attribute to disease, but taking that into account with other symptoms can be helpful. There have been early intervention studies in the pre-targeted therapy era, none of which showed a benefit to early treatment. There was a study presented at Lugano, which I thought was only worth a small line here in terms of practice-changing results. There was a German CLL-12 study, which looked at early Ibrutinib versus observation in intermediate to high-risk patients. They had a primary endpoint of event-free survival, which may not be the best endpoint for an early intervention study. So not surprisingly, there were more events when you received a placebo, but it's far too early to see an overall survival benefit, and so that has not changed practice. There will also be a SWOG study that's starting some point next year, looking at venetoclax and obinutuzumab in high-risk patients, randomizing to an early versus delayed start. This is the treatment landscape in 2019 of approved drugs. So there are CD20 monoclonal antibodies. There is chemotherapy, and so there are some familiar agents here, including fludarabine cyclophosphamide, as well as R+bendamustine. And then the agents at the bottom are the newly approved agents, including the BTK inhibitor, PI3 kinase inhibitors, as well as BCL2 inhibitors. In some ways, things have changed. In other ways, things have stayed about the same. Risk factors for CLL, this is from 2000, so this is the pre-rituximab era, looking at overall survival based on cytogenetics. And it's similar today as it was back then. Patients with a 17p deletion don't do well, especially with chemotherapy. Median survival in the 2 to 3 year range. Patients with other abnormalities did better. And this, you will see many Kaplan-Meier curves in this presentation with very similar results in 17p deleted patients. This is a retrospective review looking at this is from the CLL-10 study, This is inferior outcomes in 17p deleted patients after upfront FCR. So this was a randomized study that the Germans did, and they looked back at their outcomes of upfront FCR based on cytogenetic abnormalities, and there were only slight differences between other common abnormalities, including trisomy 12, 13q deletion, and 11q. But patients who had a 17p deletion did much worse. And this looks very similar to the curve that I showed you back in the year 2000 with median overall survivals in the 2 to 3 year range. So not much has changed since then, at least with chemoimmunotherapy. This is the landscape of prognostic and predictive markers in CLL, looking at both FISH as well as karyotype and mutation profiling. FISH is the most commonly available data. It's available. Cytogenetics is not always performed, and FISH should be performed at diagnosis and especially before treatment. Deletion 17p, as for virtually all cancers, is an adverse prognostic factor. 11q is not quite as pronounced, but it certainly is an adverse factor. And now a lot of mutation panels are being done at diagnosis as well, as the costs have come down. And even p53 mutations confer a poor prognosis even in the absence of a deletion. And then the other aspect I'll talk about as well is the mutated immunoglobulin variable region. This does appear to have an impact, but as I'll show you, it's only in certain sets of patients. An IPI score for CLL had been developed, and this is mainly applicable in terms of the survival curves for the chemoimmunotherapy era, and it's not clear how this risk will translate long-term in the targeted therapy era. But I like to show this slide because the point values, I think, tell you how much risk each factor gives, and deletion 17p gives the most risk of 4 points even on its own, and which automatically puts you in the high-risk category. Unmutated immunoglobulin variable region is a high-risk factor as well, but even other factors, including rise stage and age, don't nearly have the same weight. And then we have these nicely separated curves when you look at patients stratified by this. So very low-risk patients seem to do well almost no matter what you do, and the very high-risk patients have a very similar curve to what we had back in the year 2000 with adverse prognostic. So ASH 2018 was a big turning point away from chemoimmunotherapy. So it doesn't mean it's gone away, but it's a turning point in terms of how we should use targeted agents even in the upfront setting. And so prior to late 2018, there was no available data comparing contemporary chemo with novel agents without 17p deletion. I say sorry chlorambucil because there were studies using chlorambucil, but I'm mentioning contemporary chemotherapy regimens. And so there were 2 studies presented at ASH this year. One was the ICAHO19 study, and the other was the Alliance study. And the first study was performed in younger patients, so under age 70. And so this is historic data from MD Anderson, as well as a CLL-10 study looking at FCR. And so this is the landscape prior to the design of the study. And I want to highlight 2 plateaus right here. Here's one plateau of FCR and IgHV mutated patients, and this is their retrospective data. And this is going out 10 plus years, and a very clear plateau here. And so there's a lot of promise, particularly in this subset of patients, that FCR may be curative in this patient population. But we don't know how that compares to Ibrutinib. And so this was a randomized open-label phase 3 study that looked at patients less than age 70. So these are younger patients with good kidney function, no 17p deletion by FISH. And so 529 patients were randomized 2-to-1 to Ibrutinib rituximab versus FCR. Patients received 6 cycles of FCR, and patients who receive rituximab and Ibrutinib only receive rituximab for 6 cycles and then having Ibrutinib maintenance. I think for the sake of time I can go past some of this, but 17p deletions were excluded. And so in the primary endpoint, PFS was improved significantly in the Ibrutinib rituximab population, and regardless of subgroup, in the especially the very young population, less than age 60. And then by IgHV status, I think this is one curve that will also be replicated in some of these chemo versus targeted agent studies, is that patients have an unmutated variable region do worse with chemoimmunotherapy than those who have a mutated region. Yet with Ibrutinib or targeted agents, this risk doesn't seem to be there with targeted agents. So the target agents can work regardless of immunoglobulin mutation status. And one thing that's striking about this study is even in the overall survival, there was an overall survival benefit to this. So even though Ibrutinib was given long-term, among the intention to treat, there were only 4 events in the rituximab group compared to 10 in FCR. And remember, it was a 2-to-1 randomization. Looking at AEs in this group, FCR was more toxic regarding to cytopenias and infection. Notable side effects with Ibrutinib, not quite as high in this younger patient population. AFib was 2.9%, hypertension 7.4%. Seems very tolerable in younger patients. And so the other study looks at the different populations. This is the older patients, age 65 and older, looking at a less intensive chemotherapy regimen. So FCR is extremely toxic, particularly in patients over age 60 and 65. And so looking at a less intensive regimen, bendamustine rituximab, is more reasonable in this population. And so this was a 3-arm study, Ibrutinib plus or minus rituximab versus bendamustine rituximab. And in this particular study, I think one thing that's highlighted is it's not clear what the role of the CD20 antibody is in use with Ibrutinib. And so the PFS curves for the 2 Ibrutinib arms do have some events even later, but with the bendamustine arm, there's a clear separation between these curves. There was no difference in overall survival between these arms in contrast to the ECOG study. One thing that was interesting in this study, it did allow deletion 17p, which is very clear now that chemoimmunotherapy in 17p deleted populations does much worse and would not be recommended. However, we can analyze these subsets. So in terms of the number of patients who had deletion 17p is about 8% in the BR arm, and 27% even had a complex karyotype. And so, not surprisingly, BR does much worse with the 17p deletion. But if you have neither adverse prognostic factor, the curves do not separate as much. And so I think, and also comparing this to the immunoglobulin status, these were all the non-mutated immunoglobulin variable regions did much worse with bendamustine versus with the mutated, the curves are much closer together. I don't think this median PFS of 51 months really makes sense with this one late event, but I think one can look at this, especially with the overall overall survival being the same, that bendamustine rituximab is reasonable in a select patient population that's perhaps low risk, who understands the risk-benefit of a finite chemotherapy versus Ibrutinib. And I'll let you compare these results to the next study, which I'll talk about here, that was presented at ASCO as well as Lugano this year. But finally, safety for this alliance study. Not surprisingly, chemotherapy has more hematologic and infectious side effects, while atrial fibrillation is the major side effect that's increased over chemotherapy. And so this was a major pivotal study that was presented this month, both at ASCO and published concurrently in the New England Journal of Medicine. This was looking at the use of venetoclax and obinutuzumab in upfront setting, but with the caveat of patients with CLL and coexisting conditions. And so to show what coexisting conditions mean, the main inclusion criteria for this study were patients with a comorbidity score greater than 6, and so these could include a variety of the different conditions that patients can have, so diabetes, hypertension, and there's a calculator online where you can look up the comorbidity score for your patient. So this is for patients who had a creatinine clearance less than 70 and a comorbidity score greater than 6. So this is not going to be the typical younger patient, but it doesn't take much to get a comorbidity score of 6, particularly in patients who perhaps are over 70, 75. And so in this one, it's a fixed duration of therapy, and both arms are given for the exact amount of time. So one criticism of FCR and bendamustine rituximab being an arm is the treatment stops after 6 months, and you give the other arm indefinitely. So seeing a PFS difference doesn't mean as much as when both arms are given the same amount of time. So venetoclax and obinutuzumab are given for 6 cycles, venetoclax alone for 6, and then chlorambucil, obinutuzumab for 6, and chlorambucil for 6. So chemo given for the same amount as venetoclax, CD20 antibody for 6 months. Venetoclax was given as a ramp up over 5 weeks, and as I mentioned, obinutuzumab is given at the standard schedule. Arms were pretty balanced, 216 patients in each arm, and comorbidity scores were balanced between the arms. In terms of P53 mutations, so we talked about chemoimmunotherapy with 17p deletions does worse, but these were included in this study, and 12% of patients in each arm had either a mutation or a deletion in 17p. So looking at toxicity first, I think there weren't major differences with the exception of in the chemotherapy arm. they did have similar amounts of infections. There was some difference. They call this metabolism and nutrition disorders. It's probably related to tumor lysis syndrome. Neutropenia is the major side effect of venetoclax, and it was balanced between the chlorambucil arm. And so these are the grade 5 adverse events. And one thing that they had to talk about at the meeting that there's not a clear explanation for is why there were more deaths after completion of therapy in the venetoclax arm. So this is 5 versus 2%. So they do in the subtext talk about that one of the deaths was sepsis unrelated to treatment. Another patient had a secondary T-cell lymphoma. And so they give all those caveats there. So pretty small numbers, but at least something to look for in future studies as well. Response rates, not surprisingly, higher with the targeted agent, especially with the type of patient population we have, and this was significant. And then they marked the gray line here, and this is very important because both therapies stopped right here, so you can see very clear separation after completion of therapy, and many of the responses were durable in the venetoclax arm. And so this is where I'm going to show you some of the subsets for this study that will help highlight some of the differences and, as well as similarities between this and the other studies. So immunoglobulin variable mutated regions. So as I mentioned before, targeted agents, it doesn't seem to matter the mutational status, but with chemotherapy, if you have an unmutated variable region, this is where much of the separation happens. So in fact, much of this difference can probably be attributed to this higher risk patient population, both the IgHV mutational status as well as P53 status. So patients who receive venetoclax and obinutuzumab did better with 17p deletions, but one thing, it's hard to tell, there's so many shades of gray here, that there is a separation, so without and with for venetoclax and without and with for chlorambucil obinutuzumab. So there are still relapses. You can still see some of these late events even with venetoclax. So venetoclax is an effective option in this setting, but it's clearly one where there are still late events that happen. And there was no overall survival difference between this study with this relatively early follow-up, and venetoclax obinutuzumab was superior in terms of time to next treatment. And so this is a story in terms of MRD that's really going to start playing out, I think, in future studies as a way to evaluate the effectiveness of this regimen, but also show some of the limitations of this regimen. There has been shown in retrospective data dating back over the past 10 years, some of the German groups looked back at studies and found that patients who had negative MRD defined by less than 10 to the 4th CLL cells in peripheral blood, as well as bone marrow, is predictive of improved outcomes in this patient population. And so there was higher rates of MRD achieved both in peripheral blood and bone marrow with venetoclax and obinutuzumab versus chlorambucil, and these were all very statistically significant. And so I think to summarize the frontline treatment conclusions, Ibrutinib would be the standard of care for frontline treatment regardless of age and comorbidity. So that's, if I had to put one line, I would say that. However, there are some caveats. One can consider an intensive regimen like FCR for a very select patient population. So if someone is very young, fit, with a mutated immunoglobulin variable region, without adverse cytogenetics, and they also understand the toxicity and risk profile. There's a 5 to 7% risk of secondary MDS and AML. But in looking back at that MD Anderson data as well as CLL-10 data, there may be a clear plateau in 50 or 60% of these patients. And even among these MRD negative patients, some of the work done at NCI is showing us that even among these MRD negative patients, there's still a high proportion that will eventually relapse. So maybe some of these venetoclax obinutuzumab patients will be cured, but it's probably not going to be the majority of these patients in the long run when we have longer term follow-up. So that can be an attractive option, particularly for a younger patient, if they understand the risk profile. And then there's also, if a patient has a mutated IgHV region, no deletion 17p, and doesn't want to go on a long duration targeted therapy, knows that a short-term chemoimmunotherapy like bendamustine rituximab has its limitations, but in the patients with a mutated region, there's pretty long PFS in that population, and so somebody wants a long period of time without treatment, that can be a good option in that patient population if they understand the risks and benefits. And so this could also be a good option for someone who maybe has comorbidities that might make Ibrutinib use less appealing, so patients with cardiac history or atrial fibrillation history. And so the recent New England Journal data is very intriguing and gives us perhaps a fixed duration option, so venetoclax for 1 year versus indefinite Ibrutinib. But it's never been compared head-to-head to Ibrutinib, so it's not clear which one is better. And Ibrutinib has a very long track record in this setting, and especially for low-risk patients, very durable remissions. And so it's hard to know how to balance this in the short term without longer-term follow-up, but that's how I would summarize it for now. And I don't think it's wrong to use venetoclax, but patients should understand it's a relatively new regimen. We don't have longer outcomes with it. And so I'll transition to the relapse refractory setting. So I'll just highlight even some of these same agents that you've seen here before, looking at some of their data in the relapse setting. So there's going to be a fair number of patients perhaps who received alternate therapy and have relapsed since the development of targeted agents. So it's good to know what to expect in this patient population with these newer therapies. So at ASCO, 6-year follow-up of the RESONATE study, which was Ibrutinib in relapse refractory CLL-SLL, was presented. It was oral Ibrutinib compared to ofatumumab, which is virtually unused in the U.S., and I don't even think available outside the U.S. anymore. But in this population, half the patients received Ibrutinib until progression or toxicity. And I just wanted to put this on one slide. Patients with Ibrutinib had a median treatment duration of 41 months versus 5.3 months with ofatumumab. I left out the Kaplan-Meier curves. It was kind of a bloodbath, and I think these numbers really show you that even for multiply treated patients, there were very durable responses with Ibrutinib. So it's a very attractive option for patients with relapsed CLL if they'd received some other treatment and never received a BTK inhibitor. Other agents that are approved, but not as widely used for a variety of reasons. So Duvelisib was approved back in 2014. So this is an oral PI3 kinase delta inhibitor. And so in this study, it was compared to, so both were given with rituximab, it was compared to rituximab placebo. And so in this population, this is back in 2014, the earlier follow-up, didn't have a median PFS reach, but if you follow the curve, it's probably somewhere in the 12 to 18 month range. However, its long-term use in subsequent studies was limited by toxicity, particularly autoimmune conditions like particularly colitis, but also some transaminitis can be seen. And so while it can be a good palliative option for patients, it doesn't have the long-term durability as well as safety as Ibrutinib. And so that has to come into play when you're discussing whether to use this for a patient. And then similarly with Duvelisib, we don't have longer-term data for this. This is an oral PI3K delta gamma inhibitor. This was just approved last year. It was also compared to ofatumumab, and so it showed median PFS around 13 months. Similarly, high rates of discontinuation due to toxicity, and so this can be used as a palliative option in select patients, but wouldn't view this as a longer-term option. Why, compared to how I might view this particular study, which was looking at venetoclax rituximab in the relapse setting. And so this is a study that looked at chemoimmunotherapy in the relapse setting versus targeted agent. And so this was one where patients received the venetoclax for up to 2 years, and the bendamustine rituximab was given for 6 months. Patients with deletion 17p were included in this study, and so this is a little bit controversial, but some of the data definitively defining this was not available at that time. And so in the overall population, quite a significant difference in PFS in this population, as well as overall survival. I didn't have the curves here, but if you look at the higher risk features like 17p, a lot of the separation is defined there. But it's clear that the prolonged therapy for up to 2 years with venetoclax is superior to chemoimmunotherapy in this setting. And so this is a summary of the agents that are available, the targeted agents. And so we have Ibrutinib, so BTK inhibitor, fixed dose. And so you don't usually need to use a CD20 antibody with this unless you really need a fast response. Major side effect is bleeding, and there's some other common side effects, including rash, joint pain, and AFib. However, it requires indefinite therapy as complete responses, particularly MRD negative ones, are very rare. Venetoclax requires a ramp up, as tumor lysis syndrome is its big side effect initially, but neutropenia is really the only major side effect long-term in this population, and in the untreated setting has a fixed duration of 12 months versus 24 months in the relapse setting. And then Idelalisib and Duvelisib are reasonable options for select patients, but mostly for patients looking for a palliative treatment, either transitioning to a more experimental option or who don't have or not eligible for studies, because long-term complications, including autoimmune complications, tend to be an issue with these after 8 or so months of treatment. And so this is sort of a summary slide here. I think I want to highlight that I think P53 aberration is the major thing that must be looked at prior to starting treatment, and Ibrutinib is the clear standard for upfront treatment in this particular population given the data. There are progressions with this, even with Ibrutinib, and venetoclax rituximab is approved, but it's important in this high-risk population to start considering things like cellular therapy as soon as patients relapse off of Ibrutinib. So HLA typing, looking at CAR T-cell centers, there's studies open and in the next few years may be approved, because venetoclax is effective, but if that stops working, there are not great options. Idelalisib and Duvelisib would be palliative in this setting. And then in terms of all other patients, it's really a grab bag, and I talked about some of the caveats for younger patients as well as older patients defined by risk factors. Ibrutinib, venetoclax, obinutuzumab, as well as chemotherapy can be reasonable depending on the patient population. One wouldn't be wrong doing Ibrutinib, but it's good to look at some of the caveats because some patients may benefit from an alternate treatment depending on different factors. And talked about after progression, there's venetoclax available, Ibrutinib if they haven't received it. And so I've gotten the signal, and I actually think I'm doing okay. I just want to talk about 2 slides about the future treatments. So what is going on in the future? What studies are available? So there are safer BTK inhibitors being developed. So acalabrutinib is approved for mantle cell lymphoma. It's likely to be approved this year. There is data both in treatment naive as well as relapse refractory patients. And so by safer, lower rates of cardiac side effects, particularly AFib. There's a phase 3 study comparing zanubrutinib, which is another next-generation BTK inhibitor, to ibrutinib. This is a non-inferiority as well as superiority study in the relapse setting. And then there's phase 1 studies looking at options for BTK resistance. So there's a C41S mutation, which is common, and some agents can be sensitive to this. And then there's also safer PI3 kinase inhibitors. So a drug called Duvelisib is being tested in this setting, potentially has lower rates of autoimmune side effects with a longer-term use, though we haven't seen its pivotal data published yet. There's an ECOG study for younger patients, so obinutuzumab, ibrutinib, venetoclax versus obinutuzumab, ibrutinib, which is, I believe, open. It's not open at our site yet, but is opening nationally. And then CAR T-cell therapies. This was presented at ASCO as well as at Lugano. Don't need to go into too many details of this because I just want to show the results here, which is very high response rates in multiply relapsed patients and undetectable MRD in about 65% of patients in the marrow. And these are highly treatment refractory patients. And some of these responses are durable, but this is still in the early phases and only a few patients have been treating, but this study is ongoing. And so I think that's it. So, thank you.